Hey, good afternoon. Before I say anything, I just want to go back to the start of the conference, the opening sessions this morning with our speakers there, who brought a great weight to this room, telling their very real and very difficult stories, and really put the why to why everybody is in this room today and the importance of the work that everyone's doing. And I want to thank everyone here for being part of that and hopefully being part of some change that we really need to see in the province of British Columbia. I'm Jel Coward. I have the honour of moderating the next session on interprofessional care. I'm a husband, a dad. I have 2 kids and a cat. No, 3 cats now, since Rebecca arrived home yesterday afternoon with 2 new kittens, which I really did know about, who are probably tearing our house apart as I speak at the moment. I live in North Vancouver territory of the Musqueam, Squamish and Tsleil-Waututh nations. Also a little bit in Pemberton, Lillooet territory and also Lower Statliam territory. I'm a rural generalist physician. Alex said we should say a few words about ourselves, so I'll just try and say a couple of words. I'm a rural generalist physician. I lived in Pemberton for 15 years, served the community there and a number of outlying Indigenous communities. I know what it's like to be in the back of an ambulance doing transfers for 2.5 hours in the middle of the night. We did that quite a lot, so this is dear to my heart. I have a little bit of background in pre-hospital care. I was part of BASICS in the UK, the British Association for Immediate Care Schemes. I work with the Ski Patrol, Whistler Blackcomb and SAR for 15 years and a bunch of other things there. And I have an interprofessional heart because I feel that working in interprofessional settings is the best way for us to work in so many ways. I have to mention the word joy because I think it's very joyful to work with people from different professions. So that's, I guess, why I'm moderating this session. I also want to say that I work for Rudy for RTVS, the remote support system that we have in this province, which has been fantastic. And my shift starts at 4:30, so we need to keep on time this afternoon. But I know that somewhere between 4:30 and 9 p.m. tonight, I will be on the phone trying to arrange a difficult transport for somebody out of a difficult community, those communities that were talked about this morning. So anyway, without further ado, we should probably get on. We've got 3 great speakers for you this afternoon. And the first person I'd like to introduce is Kyle Danielson. I'll read from their bio. He's originally from BC, he told me just now. He's the Director of Ops at Airlift Northwest at UW Medicine out of Seattle, which is a multi-state academic air medical program. He's got a background spanning clinical practice, operations, leadership, and research, so he brings a unique perspective on the operational challenges facing air medical transport systems. He also advises air medical leaders on program expansion and network optimization and base positioning and all those logistical pieces. His work focuses helping programs make data-informed strategic decisions about service area design and resource allocation. He has a Master of Nursing from the University of Toronto with a specialization in resuscitation science and a Master in Public Health from Simon Fraser, where we are now, where his research focused on optimizing early activation of helicopter EMS for major trauma in British Columbia. He serves as clinical liaison to the Resuscitation Engineering Science Unit, which the abbreviation of which is RESCUE, which is kind of cool, at UW Medicine, and is active in research advancing air medical transport, health systems, and resuscitation science. So Kyle, would you like to come up?
Thank you very much. I will say my wife got a few chickens. So if anybody in your family tries to get chickens, they have the same habit of multiplying. We started with 2 and now we have 6. So just be forewarned. All right. So I've been asked to speak about the experience and perspective of flight nurses. Are there any flight nurses in the room? Okay.
That's the problem. We need flight nurses in this province.
Great. Well, I don't know if I can do the dance, but I could get some of you to join me, right? Yeah. Okay. I'm supposed to be a little more serious. Here we go. So I'm going to talk about 3 things, though, like what brought me to this work, some of the places it's taken me along the way, but also, to the speaker that was just speaking, was what makes us better as we work together as a team in the field. So a little bit about how this started. I started as a first responder in BC. I grew up on Vancouver Island. And as part of that, I was encouraged to go and learn from some of the best pre-hospital resuscitationists. And so I went to Seattle to ride on Medic 1. And as part of that, we were called to the helipad at Harborview Medical Center. The air crew had called ahead, Airlift Northwest had called ahead to say they had a traumatic arrest, they needed some extra hands. So we were to meet them at the pad. And as the flight nurses, exited the aircraft and started coordinating, and I could see their clinical leadership and really the flow of things, and also how bringing the patient into the trauma center. I didn't even know what a flight nurse was until that point, but I knew at that point I wanted that job, right? It was very exciting. It was very inspiring. And so that started me on my path. So from there, I want to talk a little bit about that. That's kind of what kicked it off for me. But where it took me, as somebody mentioned earlier, I also didn't have a direct path to where I am today. So I'll speak a little bit about that because I think there's an opportunity for nurses to grow in these roles, and I want to just speak on some of the opportunities that it also provides. So I became a nurse, though, to work for Airlift Northwest. That was the reason I became a nurse. And I started out in the emergency department. I worked at St. Paul's, actually, while I was going to grad school, and mostly in Victoria, though, at the Royal Jubilee Hospital. From there, I went up to the Northwest Territories, and I flew into Nunavik and in Yellowknife, and that was really the start. And the gentleman earlier mentioned my graduate degree, so I started to bring together some professional and academic interests, and I think that's a real opportunity for flight nurses as well. So not to bore you too much with the details, but sort of went through the system as a flight nurse to base manager to assistant chief, and now as the director of operations at Airlift Northwest. So I've been really fortunate along the way, and a lot of people have opened doors for me to be here, and I'm really thankful for that. So I want to talk a little bit about those folks, and really I want to call out the paramedics that I initially worked with, and I think a lot of people who enter the flight environment will be flying alongside paramedics, and they have just a tremendous amount to offer. They were the first ones to teach me what it's like to care for a patient hundreds of miles from where they need to be with very little resources. And they gave me the courage at that point to do it. And I will also say they were really the first introduction to clinical quality. Like paramedics have a deep sense of wanting to do the best by their patients. And so through our structured chart reviews and also just like pulling you aside after a flight to say, hey, how could we do things better next time? Went a really long way to shaping my sort of understanding of how I should approach the profession. And it's amazing the themes that are coming up. Like it's almost like the speakers got together ahead of time, but we didn't. And it's interesting because I put a note here that of all the communities we flew to at the time, I think only 3 or 4 of them had ambulances. So this idea, like the Ford Flex is actually one of the best vehicles. I'll put that out there. If you've got to put, compared to the back of a truck, Ford Flex fits a Stokes basket perfectly. You're going to put the ventilator, you're going to it all piled up nicely. So just keep that in mind if you're buying vehicles. Yeah. So just really fortunate and thankful for flying alongside paramedics at Airlift Northwest. I'm going to get into some of the nuts and bolts of airlift tomorrow, but we fly a nurse or nurse physician crew, though many of our nurses are paramedics as well. Coming in the U.S., as you know, it's very common to sort of fly a nurse-medic combination. And I'm happy to get into more of that later. So also physicians, as we sort of go through the interdisciplinary stuff here, teaching and learning from physicians. I've learned a ton from the attendings at Harborview Medical Center, UW Medical Center, and our own medical directors at Airlift. We have one medical director and a series of associate medical directors with various specialties. But I've also now had the privilege of supporting our flight physician program and giving them the resources, the education, and the training they need to be successful in our environment. So that's part of the Department of Emergency Medicine at the University of Washington. And our flight nurses spend a lot of time with these docs as they come up through the ranks in the residency, at different levels of responsibility, training them to be flight physicians. So they really start in an observer role and then graduate up to a fully qualified flight physician. Nurses and physicians work side by side in the education at Airlift because of that. So at all levels of the education, the medical directors and our resident physicians and attendings are all a part of that. So that's what interdisciplinary practice looks like at Airlift. But in the aircraft, when it's just the two of you in the back, it really comes down to your knowledge, your training, your experience, your capabilities. It sounds like a lot of people have had a similar experience, maybe not in the back of an aircraft, but in other situations. But in the aircraft, you are one team. I do want to extend that a bit because we haven't talked about it today, but an air medical team extends beyond those that are in the helicopter or in the plane, because your maintainers, your mechanics, your operational control center, your dispatchers, all of those things need to come together. That's all part of the crew, so to speak. But to do this job and to do it well and to do it safely, there's actually a fair amount of aviation knowledge you need to gather. And our pilots play a huge role in that education for us. So they're integral to that. Every day we have a safety briefing in the morning, and we go through various topics, aviation topics, and that's a gap we've tried to fill too with some dedicated training seminars and conferences just related to aviation knowledge and decision making, because you all need to agree that it's a safe flight to go on before you leave. So we sort of do the 4 to go, 1 to say no, because we fly in a 3, either 2 providers and a pilot plus our dispatch. So that's the 4th. But what else do I want to say about this? We also, it's interesting, because there's different ways of integrating flight physicians, and hopefully we'll talk a bit more about this. We, though I might fly with a medical director, what we're going to do in the aircraft is going to be very similar, and we have a very collaborative way of working together. So there isn't a really big hierarchy, if you will, and that really just mirrors how we train as a team. So I want to talk about research just a little bit, because this is another opportunity, and I think it really goes hand in hand. I think when you're working with people who are committed to advancing the science of your practice and what you're doing in the world, there's going to be a lot of opportunities for research. I had that at SFU, as I mentioned, where I studied the early days of the BC Auto Launch program, and that capstone came out in 2009. And I'll just point out that a lot of the things that we uncovered at that point were, with regards to delays, or things I've heard earlier today, unfortunately. So it wasn't uncommon in the flights that we reviewed that patients would be moved up to 6 times before they reached definitive care by cars, boats, planes, whatever it might be. So it's unfortunate that's still continuing, but it's definitely an opportunity. And we touched a little bit on rescue, but multidisciplinary teams, nurses, paramedics, scientists of various types, and physicians are part of these groups. And so if you're not part of one of these, I really encourage you to. I think it's a great way to be working together. I also want to just mention, an opportunity as a flight nurse to engage in some of the and address some of the system-wide challenges as you bring together various interdisciplinary groups. Inevitably, you're going to be coming from different organizations. And we could talk all day about this, and I know there's some experts in the room who focus on this, but all of those organizations, if you've got clinicians, maybe a hospital group, an aviation group, and others coming together, they're going to have their own quality management systems and their own safety management systems. And how those integrate and work together is something you should really take a pause and address, so you're not having to retrofit that stuff like I am now. All right. So another theme that I wanted to point out, this is just a map of Washington, and it's actually also showing the medevac flights. So these are, if you mapped out the actual medevacs throughout Washington state, this is just a 2-week period. But to various hospitals at different capabilities. But I sort of categorize it as the connection between your patient, your provider, and your place, right? And I've heard that a few times today. Is like, what is the right combination of those things as we think about interdisciplinary? Whether you're going nurse, physician. I heard about combining additional physicians. You need to think about that first as you start to build out your practice. And a good example of that, and I apologize, it's kind of a high acuity example, but others have mentioned ECMO today. ECMO is a good example of this. You've got paramedics in the field who are doing their best to resuscitate patients to get them in extremis to a hospital. And then at Airlift Northwest, we combine providers to add. This is our medical director there in the middle, Dr. Udar-Natchit's in the middle. We got Dr. Bajalik. She is on the left. She leads the ECMO program at UW Medicine. and there's a couple of flight nurses and our ECMO specialist. But this is a really great example of bringing people together with the right combinations of skills and experience. And also we do, ground, fixed wing, and we're getting into rotary wing now for primary and secondary cannulation. So this is one of those times where figuring out where and what combination of things do we need to put together to meet the need. And so this is my last slide. I just want to mention, hopefully I've touched on the fact that I've benefited from interdisciplinary practice throughout my career, and at each step, and I'm thankful now to be able to give back some of that in my current role. But as we have the experts in the room over the next day or so, it would be great to engage in conversations. We're coming from different backgrounds and experience, but there's the right combination of things in this room to do something pretty amazing, and I'm excited about that. So I just encourage us to have those conversations, knowing that we may not see eye to eye, but that we all have a shared focus on the patient and what's best for the patient. Thank you.